All right, many thanks, Ibrahim Bello Gunda, for that background report. And now joining us to discuss pushing for affordable health care. Let me introduce here in the studio first Dr. Salma Ibrahim Anas, who is a special advisor to the President on Health. We thank you for joining us on Good Morning Nigeria.
Thank you. Good morning. Good morning, Nigerians.
All right, we also have joining us for the conversation Emeka Ogwanwo, Senior Partnership Manager at Nigerian Health Watch. Many thanks for joining us.
Thank you very much for having me.
All right, let's begin. Let me begin with Emeka, by the way. Help us understand the big picture. What exactly does universal health coverage mean for an average Nigerian family?
Thank you so much for that question. I mean, I think that's a good starting point, really. When you think about universal health coverage, or UHC, you're basically speaking to every Nigerian being able to access health care at an affordable cost. Like accessing healthcare doesn't put a financial burden on the individual or a financial strain on their productivity. So that's essentially what they should know. Their ability to, whenever they feel ill, get the care they need, recover, have a health system that supports their growth and recovery, especially, and also productivity as well. So that's essentially something what for the average Nigerian should remember.
All right, many thanks, Emeka, for your opening comments. I'd like to get to Dr. Anas now. That's like what universal health coverage should be. But, I'd like you to, speak to us about why it's important that healthcare is affordable at this time, and about some of the policies. I mean, you speak for government. Some of the policies that are in place to make healthcare affordable for Nigerians.
Yes, thank you. So in addition to just a little of the background, it's, countries came together because of the poor health status of the whole world and said that let's commit to it. And Nigeria committed to it, to that declaration. So this is very essential also to note. And we have to commit, we have to deliver based on the commitment we have made globally to ensure that we ensure quality health care is delivered to the people of Nigeria, all Nigerians, irrespective of who you are, where you live, your socioeconomic status, at an affordable, he has said it, to ease hardship, financial hardship. So yes, we have been confronted, just like every other country, with financial hardship and burden, of the cost of healthcare services. As we know, Nigerians, almost 70% or more, pay out of pockets, which means they purchase services on their own. And this adds gross additional burden on families and compete with other priorities like food and education. So what we are doing in Nigeria as part of our efforts to meet that commitment is to ensure that every Nigerian have access to quality healthcare services, within their reach, not far away from where they are. And we describe it as 30 minutes walk, shouldn't be more than 30 minutes walk, or half an hour walk to access quality healthcare services. And then using the platform of the primary healthcare, facilities to provide the basic needs of all Nigerians at that services. So if you look, you will observe that Nigerian has been on this journey for quite a very long time. And we are yet to realize fully, it's still work in progress. But a lot of efforts have been put in place in the last few years. Since the National Health Act was passed since 2004, it was passed in 2024 and then 2014 and became operational in 2019. So what that means to us, it shows the highest level political commitment that has been sustained over the years. Since the time of President Goodluck Jonathan, it was endorsed, and then the time of his late President Muhammad Buhari, it became operational. And I'm glad to mention that also under this administration of President Bola Ahmed Tinubu, it has been sustained and also it has been kind of expanded to ensure more coverage and enrollment of vulnerable people in the scheme under the National Health Insurance Authority and also at the subnational level, the State Health Insurance Authority. So in terms of policies, this is a policy that has been ongoing for the past 20 years, and we've made a lot of progress because today we are witnessing a country where 1% of our consolidated revenue fund allocation is being dedicated to address the issue of healthcare in Nigeria, and addressing it at the level of the primary healthcare level, making it functional, revamping our primary healthcare, making it effective and functional, and also the other pathway is through ensuring that we expand the coverage. And this has doubled in the last 4 years. Our coverage, if you looked at the information that is currently being generated in terms of coverage of healthcare, it has increased from 3% as of 2020, just in the last 2 to 3 years, 2022, 2023, to now in 2025, the coverage has increased from 3% to almost 11%. So what it means in terms of numbers, it means that we have moved on to increase from almost 11 million people to almost about over 21 million people currently are covered by the insurance. So this is a policy direction that has been driven, and it's not only at the national level, even at the subnational level. All states of the Federation today, they have a state health insurance scheme. They're operating at different levels. And a lot have also committed resources after they created the state health insurance schemes at that level. So these are some of laudable efforts that happened in the last just few years to reduce hardship, you know, in terms of access to quality healthcare services in the country.
Laudable efforts, no doubt. But of course, if we say we are heading to 100% and we are still around 11% or so,
we are enrollment.
That means we are
from
still very
3%, we now increase up to 11% in just about 3 years. So the target was to achieve actually less than that. Every year we have a target.
So we are still
we
left
will
with
surpass the target. We surpassed the target of 2025 because today we have an enrollment of over 21 million people. So for this year, the enrollment was supposed to be at about 18 million.
So we've made some progress.
So we've made a drastic progress because we even surpassed the target.
Right.
Because this is not going to happen in a day. You know, it's a milestone, and it requires a lot of efforts, a lot of resources, and also ownership also, and involvement of more players beyond the government.
So we are still left with almost 80% uncovered. But apart from that, even those that are covered, there are still things that befall you health-wise today that you still have to probably go into poverty. That is, if you have poverty to reach, because of the level of coverage. And I'm talking at the federal level. So the coverage, could it still be said to be universal, even at this level with the NHS?
You know, the aim, our goal is to achieve universal healthcare coverage. No one should be left behind. And what does that mean? Everybody. But most of our focus as government is to ensure that the vulnerable people are covered. You know, vulnerable people, these are women of reproductive age group, you know, poor women, children under 5 years, adolescent, elderly people, you know, should have access also because their illnesses and health burden also increases. People with disability. And then people also that suffers a kind of a mental health problems. So those are people that is a must, and the government is focused on ensuring that they are well protected. But remember, we also have private sectors that also have another pathway of ensuring that people in the private sector also have access to health insurance coverage. So this is the whole idea. So it's not like before this commitment where we say, well, everybody takes care of themselves. But now the whole world realized that we cannot move forward with majority paying out of pockets, you know, very expensive, and it's quite devastating, you know, on the economy, on the home, on the families, and on their communities, considering other priority areas.
All right, many thanks, Dr. Anas. I'd like to get back to Mika now. Dr. Anas has spoken about what government is doing, but we know that, I mean, government is dealing with quite a lot of stuff. So what role can the private sector play, really, in making healthcare affordable for Nigerians?
Well, thank you very much. You know, I think the private sector has started to be, you know, play a bit more of an integral role in the delivery of healthcare in Nigeria. When you look at the work associations like the Private Healthcare Federation of Nigeria is doing, you know, in engaging the government on health reforms, policies, ensuring effective delivery and inclusivity. You know, you start to see how they are trying to unlock various opportunities aligned with the government's health priorities under the 4-point agenda. Dr. Salma Anas rightfully mentioned the government is working towards revitalizing PHCs nationwide, over 17,000 of them. Some have been revitalized already, which is very key. And maybe just to say that the PHCs are meant to be the first point of call for healthcare in Nigeria. If Nigerians, if the average Nigerian can ensure that they know their PHCs, right, and visit them when ill, they can prevent 70% of they can prevent the need to go to secondary and tertiary facilities, right, in 70% of cases. So that's just to say that the PHC, revitalizing the PHC, making that a goal, is very fundamental to achieving universal health coverage on the long run, right? Then where the private sector can come in. Of course, we know that that is an ambitious target, right, to revitalize all PHCs across over almost 400, was it over 400 local governments? 700 local government.
Over 700, yes.
In Nigeria. It's quite an ambitious plan, right, or goal, because the government has competing priorities. There's insecurity, there's food security, right? The government has to make, very important decisions on how to allocate resources, right? We keep advocating for increased health spending, but at the end of the day, you know that there's the limit to what the government can do, and that's where the private sector then comes in. How does the private sector work hand in hand with government to establish, measurable and impactful public-private partnerships that can ensure the government achieves that goal of revitalizing over 18,000 PHCs nationwide, right? That's on one side, right? That's a very big opportunity. And when you talk about supporting the government, you talk about optimizing PHCs, right? There are various institutions that are investing towards optimizing PHCs. So sometimes the government, they have to still make use of the budget they have and make the best use of it, right? And sometimes the budget that is available might not be adequate to ensure that a PHC is fully functional in line with what a standard modern day PHC should be, climate resilient and very, technology friendly. For instance, for the basics, ensuring that PHCs are able to collect medical records electronically, right? That is where we are now. So you now have the private sector coming with their expertise to support this in ensuring that this is possible, right? Through various PPP models that speaks to how they can work together. We look at what NISA Premier did with Gariki, the Gariki Hospital, those kind of PPP. How can that be translated at the PHC level? That's what they should be thinking about. And of course, there are a lot of conversations happening, like I said, with the HFN and other private sector organizations in line with this.
You mentioned, electronic medical records. Now, how can technology, help us bridge this gap? I mean, the healthcare access and affordability gap. Yeah. Are there roles that, technology can actually, play, and how can we, adopt that in our health sector?
Absolutely. I mean, when you talk about electronic medical record, that's like basic technology, right? To ensure that there are medical records management systems in hospitals. Big hospitals have them. We're talking about ensuring they are available at the PHC level, which often is not funded, right? There's a reason the government made it a goal to revitalize those PHCs, because they are not in the condition that they should be. There are so many of them that are thriving. There's been efforts over the years to even revitalize them prior to now, right? But it's still not optimal to serve Nigerians, right? Especially at the community level. There are areas where, then there are due to be so many reasons, even insecurity, the large expanse of land, places like the north, right? Sometimes some PHCs are hard to reach. So even if you want to revitalize them, right, it's difficult, right? So this is where some private individuals or private sector organizations come in. Organizations adopt PHCs. We've seen the PSHAN long-standing campaign on adopt a PHC, right? Those are efforts towards encouraging. It could be individuals, average Nigerians, philanthropists, or private sector organizations to really identify PHCs around them, 1, 2, as many as possible, and focus on ensuring that they are fully functional to serve the needs. I mean, a lot of healthcare organizations are doing this, but of course you can go beyond that. But let me even just say just very quickly, an example, which is the main question he asks, of how technology can help improve this. Beyond the medical records is still in line with medical records. Is the ability to use technology to monitor the consumption of antibiotics, for instance, where you can use it to address antimicrobial resistance, which we know is a very big thing. The WHO and the World Bank have dedicated this as one of the biggest threats of the 21st century, right? So it's such we've seen a private sector organization like Drugstock in Lagos that have said that they can't monitor antibiotics consumption, right, and feeding that data to the government, right? Through these are some of the insights that came out of a workshop Nigerian Health had organized with the private sector to really understand how the private sector can play a role in addressing the national burden of antimicrobial resistance in collaboration with the NCDC and some partners. So these are classic ways where private sector, they make up about 70% of healthcare service providers nationwide. There's no way you can ignore such numbers or the capacity they have and the potential they have to support what the government is doing. When you think about the pharmacy you're going to go and buy your drugs, is it a government pharmacy? Do you understand? So it's not a government pharmacy, right? They are mostly owned by the private sector, right? So imagine having technology that you're able to monitor each antibiotics that is consumed in the country, of which this should be regulated as well. Ideally, according to our national drug policy, antibiotic sales should be monitored. But the question is it, right? Now you have a private sector organization saying that they have the potential to do this. So if they can, how much more other private sector organizations, other pharmacists? Now, how about our regulators, right? Now, study these case studies, right, of what is working well or where it can work well, and see how it can be adopted to review and update our national policies to ensure that antibiotics are regulated. So that's just an example of how technology can be used to address it.
Now, Dr. Anas, from your experience as a practitioner, which group would you say is the most excluded from healthcare access, and why?
Of course, they are the people I described as the vulnerable people. Those are the poor people that cannot, afford to pay for services for themselves and for their families. Especially in the recent years, we notice a lot of escalation in prices, of drugs and commodities. It has been known, but it has really become more remarkable recently, which made it out of reach of so many Nigerians. So under this administration, even prior to it, this was well recognized. So when we worked on the policy direction of the President Bola Ahmed Tinubu, we recognized that as a major challenge, in the delivery of healthcare in Nigeria. So one of the pillars is to ensure that we reduce hardship. How do we reduce hardship? There's two ways to reduce the hardship. Is to ensure that Nigeria becomes self-reliant in its efforts to ensure that drugs are available, all medicines are available, basic equipment are available, including vaccines. So one of the pillars is to ensure local manufacture, of drugs and commodities. And I'm glad to mention a lot of progress have been made in that area, which started with the establishment of the Presidential Health Care Value Chain, office as a DEX office to coordinate that, and this is working in the last 2 years, and we've made a lot of awareness creation, just as he mentioned, and the major partner in that are the private sector. So it's to also harness the resources in Nigeria, the capacities in Nigeria, and to create an enabling environment that will enable the private sector to thrive in the country. And these efforts have been on in the last 2 years. Private sector today are very active, and they've indicated desire to be able to be part of it. And then at the level of the presidency also, to create that enabling environment, executive orders have been passed by the president, one of which is around the area of removal of taxation and value-added tax in the importation of pharmaceutical ingredients, the active pharmaceutical ingredients, and also in the importation of, apart from the raw materials, also in the importations of medical equipment. So if you observe, more than, I can see, I don't have the exact figures, but more than 70, agreements have been signed with international pharmaceutical companies across the country. And then if you recall the visit of the president to Brazil, one of the major areas that he discussed with the government of Brazil is how do we transfer knowledge and skills to Nigeria that will also strengthen our capacities in the country to be self-reliant in the area of manufacture of medicines, the overall pharmaceuticals and vaccines. And this is already ongoing. We've already signed the MOU through the PVAC office, and efforts are ongoing to see that Nigerians also start the production in the country. So that is a major way which our investment is already ongoing, and we are attracting a lot of foreign investment also in that direction. So with time, Nigeria should be able to see reduction in the cost of private.
In spite of all of this, can we really attain universal health coverage without fixing shortage of doctors, nurses, and even diagnostic facilities?
So the answer is that no, we cannot achieve universal health care coverage without adequate quality human resources. And these are the doctors, the nurses, the midwives, the pharmaceuticals, even the technicians, laboratory technicians, and all, including auxiliary healthcare providers. So this has been a major gap, not only in Nigeria, but globally. But Nigeria has stepped up to address the action of human resources, in the last few years. If you recall, the policy on migration of human resources was approved by the president himself, which means that how do we work, to ensure that we reverse, the brain drain of our healthcare providers? What are the push factors that push them abroad? And then how do we ensure that we pull them back and have them? So part of the effort that we have made is also to look at the huge gap. It's a huge gap. And then how do we improve the quantity of healthcare providers that we produce? So in the last few years, we have stepped up production of healthcare providers. Medical schools have been accredited. From the last time I knew, from about 40-something medical school for training of medical doctors, today we have about 63. And this is where also the private sector come in. So a lot of schools have been accredited, that meet the requirements for training of medical doctors. The same thing also applies to the nursing and midwifery, which are also huge, resources for delivery of healthcare services.
All right,
in
many
Nigeria.
thanks, Dr. Anas. Because of time, we know we need to round up the conversation as fast as possible. Another gap a lot of critics say we have in the health sector is that of education, health education on the part of the populace. Because, a lot of people think that if the average Nigerian is properly educated health-wise, some ailments and issues that we're dealing with in the health sector, will be drastically reduced. So, are we looking in that direction?
Definitely. In fact, you cannot achieve UHC without an informed populace. So PHC cut across, and it starts from health promotion. These are the essential key components of delivery of achieving universal health care. It starts from health promotion, health prevention of ill health, and then before you talk about the treatment, rehabilitation, and the palliative care. So, of course, health education is a pillar in this administration Renewed Hope Health agenda, that we must create awareness. We must empower Nigerians to be able to be conversant with how to live healthy. That starts with the health promotion aspect of it. You don't have to be sick, but it is a collective responsibility, and it is a responsibility of everyone to know about how to take care of themselves, how to prevent yourself. So a lot of efforts are going to ensure that we fully integrate health education, awareness creation within all our healthcare delivery in communities, and also within, and not only at the national, but most importantly at the subnational level. And it is interesting to note that Nigeria has had a system of health promotion up to the lowest level, the local government level. If you go there, you will see they have desk officers that are called health promoters or health education
But of course,
officers.
they would need to be strengthened.
But they need to be strengthened in terms of their capacities, in terms of their outreach activities, because they are not supposed to sit within the off comfort of their offices or clinics, but to move out to communities, to educate the communities, to also have ambassadors or champions within communities that will continue to do awareness creation within communities. So these are efforts that are currently ongoing, but of course there are huge gaps. It's still work in progress.
What about agencies that are supposed to ensure standardization, or if you like, regulate products that are, that are regarding to health? Say for example, there are a lot of stories of fake and substandard products everywhere, and that's also limiting our fight with all these efforts. So what are we doing?
So there are agencies, there are regulatory agencies. NAFDAC is one of them. regulating what goes out in terms of it, and also doing a lot of awareness creation on how people will read the label, because they have a label now on it to know that whether they are of quality standards, whether they have been approved for consumption by individuals. So apart from NAFDAC, also the NCDC, the organization that is responsible for control of communicable diseases in Nigeria, and also non-communicable diseases, they have a full component that looks at risk and communication, and there are lots of risk experts. But these have to be replicated at the subnational level. So because all our efforts at the national level, it's all about the policy drive, it's all about the coordination efforts, the monitoring, and then putting the standards, as you said, the guidelines. But in terms of the execution, that is the implementation, this must happen at the subnational level, mostly at the local government level. So at that level, what we lack, and efforts are going to do that, is to build capacity. We need to be on the same page. If you recall, the first thing that was done when this administration came on board was to sign the compact with the subnational governance. And this means that everybody aligns with the priorities and the vision. And we have one agreement in terms of what we want to deliver. So the state also have a responsibility. So there is need to create that awareness at that level. There is need to have the structures. There is need for them to also dedicate adequate resources. When we talk about 1% consolidated revenue at the national level, this is just a little contribution by the national government. But at subnational level, we need to begin to see ownership and also allocation of resources by the subnational government. Let's say they allocate at least a minimum of 10% to 15% of their resources also to healthcare. That will make a huge impact. And that will really make it possible for Nigerians to realize the universal healthcare coverage, where no one will be left behind.
All right. Thank you. Thank you, Dr. Anas. Let's quickly take the messages that we have and get Emeka to respond to them. Now, this one reads, "Good morning, Nigeria crew and the wonderful analysts in the studio. I thank the government for the initiative in pushing for affordable healthcare for the citizenry. I want to ask, will it cover the rural populace who are vulnerable to the health challenges? What modalities would you use to ensure the affordability and accessibility of healthcare?" That's from a TSA Jonah Udoyang from Uyo. And this other one is from Suleiman here in Abuja. "I want to ask, I have registered with NHIA. When we go for some treatment, they will tell us NHIA doesn't cover some of the medications. Can you tell us why?" I guess Emeka will take one, and the other one has to definitely come to Dr. Anas for it.
Thank you. I think I'm glad that it's obvious which one came to me. So for ATS Jonah, I would say that, it's important we understand the essential components of UHC. The first is population coverage. You want to ensure that you're reaching a significant amount of the population. Now it's 11%, but are there things that can be done to scale that gap, to scale our progress in achieving that gap? Are the UHC targets of 2030 even achievable? I'll give you an example of an innovative idea I once came across. Sometime early this year in August, the Presidential Initiative on Unlocking the Healthcare Value Chain and the National Health, the NSIA, National Sovereign Investment Authority, they had this event as like the Dragon's Den, but in the health sector, right? And where the health, I think health, education, and agriculture, and food security. So you have young people come to pitch innovative ideas of how to address critical issues across the sector. And one key idea stood out for me. It was a young man who was improving access to health insurance by getting people to recycle their waste water bottle, right? And these are mostly people who fall under the vulnerable group. Even people like market women, right? Traders, Okada riders, various other types of people that work within the informal sector. Let me put it that way. And I think his pilot started in the market where he got traders to actually trade in. If you can collect up to a packet full of bottled water, the empty packs, and trade it into him. He created a system where if you trade it into him, he buys it, but instead of paying you cash, he gives you health insurance coverage for a defined period, right? I found that idea so innovative because his target was to help improve or accelerate the process, right, of expanding health insurance coverage. Although it's important to point out that that could be very suboptimal compared to what the government is doing. But what he's helping to do is to collect data of people, basically helping with the first step, which is enrolling people. So we're still on population coverage. The second is service coverage. You want to ensure that you have the full suite of health care services that will cater to the people, quality health care services, if I'm to add that as well. And the third is financial protection, which is what I stated in my first question, that the essence of universal health coverage is to ensure that people can access quality health care without financial hardship. You don't want to, so we have the statistics, 1 in 4 people face financial hardship from accessing healthcare. That's WHO data, right? So why is it so? So that is a significant problem. Over 70% of Nigerians pay out of pocket, right? So if we have if we have such ideas that help rope in people into the health insurance system, then you can now take it from there. At least you've done the next step. The government can now explore means to work with the private sector to expand the services they get and the quality of services they get, and you continue to add on from there and build from there.
Right.
So thank you.
Dr. Anas, the other question basically talks something I had asked earlier, because even the coverage that we have, what's the quality? To what extent does it cover? That's what it's asking.
Yeah, so as I said earlier, through the Health Insurance Authority, we've covered almost 20%, which is above the target for 2025. And we also are looking at also all other opportunities and innovations, just like he has mentioned, to traject, the coverage.
But when he's talking about the quality of coverage, so and when you have certain things, they say the medication is not covered.
So the quality of services, as I said, is to provide the basic medical healthcare services. And we've even gone beyond the basic at the moment, because we are even looking at health illnesses like cancers. And recently, just about 3 cancer centers have been established in the country, in Edo, Enugu, and I think at Katsina also, in addition to the existing one. So yes, we are expanding to reach much more people, but the whole idea is to meet at least the basic minimum needs that, just like he said, that causes more than 70% of our problems that could be addressed at a primary health care. And those problems that we neglect and see are minor. They are the ones that escalate and become serious complications in the future. If you have hypertension, you don't know you have hypertension. You are just walking around. But if you do your medical routine at a PHC clinic, it will be detected very early. And it will be averted from becoming a severe hypertension that will lead to complications of heart, leading to heart failure. So this is how it works. The same thing with diabetes. You check your blood sugar, but if you have access to health promotion information, it also talks to you about your dietary. What is the right thing to eat? Also, as we say, what you eat is what makes you, and that is what leads to your health illnesses. So you have access to health promotion, health education, the type of diet you eat, and also risky life behaviors like smoking, alcohol consumption, high concentration of sugar and carbohydrate, high concentration of salt, and all the white things that we say like flour and all that. So once you have the information, it helps you also to remain healthy and keep healthy. So the whole idea is to provide the basic minimum services.
At the PHCs?
At the PHC levels. Doctor, that will also, if they are effectively working, safe, effective, and people-oriented, as we say, because people also have to be attracted to the services that are made available before they can also take those services in terms of privacy and confidentiality.
All right, Dr. Anas, as we begin to round off, I would like you to speak about areas we need to look into just so that we can make healthcare affordable, if you like, better for women and children, because they seem to be the vulnerable group, in all of this. What more should we be doing?
So, yes, thank you so much for raising that. We should be doing more because it's realistic and it's possible. with genuine and transparent commitment to the cause of it, dedication of allocated resources, and ensure judicious utilization of the resources in terms of commodities, in terms of the other services that will be provided at the primary healthcare facilities for women. For example, we have started what we call the MAMI project, which is an innovation and initiative to reduce maternal death and improve child survival, especially children, under 5 years. And this seems to be working. And this is targeting about 172 local governments that have the highest burden of maternal death in the country in 33 states. And it's working because they've provided all the essential services, in terms of drugs, in terms of everything for antenatal care, pregnancy, and then delivery. And also they've provided what we call the emergency transport services. So even if you are at home and you have an emergency, it's just with a call, they will immediately pick you up and ensure that we've addressed the issue of delay in accessing the healthcare facilities. So what I am saying is that all this cannot be done alone by government, and we cannot continue to depend on donor support, because currently we are dealing with dwindling resources from the donor funding. This is an area that I strongly believe with strong commitment, especially at the subnational level, especially now that the president has revamped the local government level, allocation of dedicated resources, and ensure that we follow through, that the resources are working for the intended purposes is doable, and we can realize improvement of maternal health, improvement in our child survival. But most important backbone of it is also, as we said, awareness creation.
That awareness creation, by the way, I'm currently doing a research on use of social media, in dealing with pediatric health conditions, as a way that, you talked about the primary health care. If mothers are aware of, the basic things they need to do for their children, of course, that could go a long way in taking care of the children. But I want you to speak about, all these initiatives by government are great, but monitoring, I do not know whether it's monitoring that is lacking, because I remember there was a particular program that was rolled out by the federal government for dialysis, and the cost was reduced. Right here on this program, we got a message about a particular federal government institution that wasn't, carrying out that initiative. The cost wasn't reduced. So what can government do to ensure that these policies, as planned, get to the average Nigerian who needs it without anybody trying to,
So I'm happy you raised that, because there's what we call good governance, even within the health sector, clinical governance. And this is grossly lacking, just like it's happening all across sectors of development. But this has to do with life saving, and it becomes very glaring. When you don't have an institutionalized clinical governance within delivery of health care, and this captures the area of the monitoring, because there must be effective supervision and monitoring all through the delivery of the healthcare, from the beginning of the planning, the conceptualization, to the implementation of it, and then seeing the outcome of it and what are the gaps. So clinical governance remains very critical, and this is what has been done in developed countries, and it has to be also our human resources, performance-based. These are things that we wanted to institutionalize, especially at our health facilities. You have a health worker that does not even go to work and can come in any time and work few hours and get their salaries. And then at the tertiary level, you have healthcare providers as consultants. They spend less than 5 hours in a facility, get their full pay at the end of the day, and then most of them have private facilities that they own. So we cannot move forward until we institutionalize clinical governance and performance-based incentives to our healthcare providers. And countries that have developed, you go to UK, it's the same thing. You are paid based on the hours that you have worked. If you are a surgeon, you are paid based on how many surgeries did you perform this month. And sometimes you find even a resident doctor earning more than his own professor or his mentor or her mentor, because of the performance-based incentivization. So this is grossly lacking in our healthcare systems. And these are areas that we need to plug, we need to address, in addition to corruption, theft, pilfering,
We've
and
run out of
diversion of our medical equipment also to private facilities. Because you cannot, it's a conflict of interest. You
Sure.
cannot be in a
Dr.
public facility as a medical personnel and then you are comfortably running your own private health facility. It's not possible.
I guess it's something government will have to deal with, but we've run out of time completely for this segment. Dr. Salma Ibrahim Anas, Special Advisor to the President on Health, thank you very much for your time and your thoughts on the program.
Thank you so much.
Let me also thank Emeka Ogwanwa, Senior Partnership Manager at Nigeria Health Watch. Always a pleasure hosting you.
Thank you for having me.
All right, that's our first conversation. The next one comes after this break. Please do stay with us.